my session and then the basic surgical anatomy of that. Actually, it is so much difficult to deliver this lecture in this short period, but I am trying to give some surgical landmark of neck. So now, which area of the body is neck? Neck occupies the space between the clavicle and thoracic inlet inferiorly, and to the base of skull and inferior border of mandible superiorly. Surgical exploration of the neck is often described as being akin to safari in tiger country, owing to its intimately arranged group of vital structures. These are the contents of the neck: skin, cervical fascia, muscles, vessels, nerves, lymphatics, viscera. First of all, the skin. The skin of the neck is flexible, thin, and intimately related to subcutaneous tissue and embedded platysma muscle. It is essential to maintain an incision line along the skin crease during neck surgery for optimum healing and good osmosis. Now the cervical fascia. Cervical fascia is critically important for fundamental understanding of surgical neck anatomy. It is utilized for surgical access to obtain a clean and avascular plane of dissection, and it also serves as natural barriers. This is the cervical fascia, which is divided by superficial and deep fascia is also again divided in investing layer, pretracheal layer, prevertebral layer, and carotid sheath. Now the superficial cervical fascia, which lies between the dermis and superficial layer of deep cervical fascia. It envelops the platysma. The superficial veins like external jugular vein, anterior jugular vein, and multiple communicating veins, etc., and lymphatics exist within this loose areolar tissue plane between the platysma and superficial layer of deep cervical fascia. And deep cervical fascia, superficial layer of deep cervical fascia invests the sternocleidomastoid muscle, trapezius muscles, parotid, and the submandibular glands. Muscular layer invests the infrahyoid disturbed muscles as well as mylohyoid and genuhyoid muscles. And visceral layer envelops the thyroid, parathyroid, esophagus, and also the laryngotracheal complex. And deep layer, prevertebral fascia prevertebral fascia covering the vertebral bodies and paravertebral muscles, and carotid sheath enclose the common carotid artery, internal carotid artery, internal jugular vein, cranial nerves 9 to 12, and cervical lymph nodes chain. Now some tips for regarding this. That is that during neck surgery, skin flap should be elevated in subplatysmus plane, staying superficial the vessels existing in loose areolar tissue between the platysma and superficial of deep cervical fascia to avoid the initial disturbing bleeding. And should respect the fascial plane of different compartment to get a bloodless surgical fit. Now the important muscle of the neck, of which sternocleidomastoid muscle is very important for our head neck surgeon. This is the largest and most superficial cervical muscle. It divides the neck into anterior and posterior triangle. It covers the important structure of the neck, like carotid sheath, spinal accessory nerve, etc., like a Pandora box. Relationship of various important structure with superficial and deep surface and also anterior and posterior border of sternocleidomastoid muscle is very much crucial. These structures are encountered at various stages of neck surgery and helps the surgeon for anatomical orientation. This is a picture which shows that the superficial surface of sternocleidomastoid muscle is crossed by the external jugular vein, great auricular nerve, transverse cervical nerve, and deep surface of the sternocleidomastoid muscle is related to carotid sheath, ansa cervicalis, phrenic nerve, omohyoid muscle, spinal accessory nerve in its upper part close to the digastric muscle. Anterior border also related to transverse cervical cutaneous nerve and some communicating vein, and posterior border related to laser occipital nerve, most important spinal accessory nerve, supraclavicular nerve, and external jugular vein. Now, tips for this muscle dissection, that is, that during the subplatysmal flap elevation over the sternocleidomastoid muscle, greater auricular nerve may be sometimes confused with the spinal accessory nerve. Remember that great auricular nerve parallel and posterior to the external jugular vein, and anterior superior direction towards the parotid gland, and spinal accessory nerve deeper and beyond the posterior border of sternocleidomastoid muscle, and its direction in posterior inferior direction towards the anterior border of trapezius muscle. Tips 2. Dissection along the anterior border of sternocleidomastoid muscle in plane between the superficial and middle layer of deep cervical fascia allows the surgeon to enter the corridor of deeper structure like carotid sheath and so. And be aware of communicating vessels at lower part of anterior border of sternocleidomastoid muscle to avoid this area, to avoid the cumbersome thinking. Now the step muscles of the neck. These are again arranged in two planes, superficial and deep. Superficial plane, in superficial plane there are sternohyoid and superior valley of omohyoid, and deep is the sternothyroid and sternothyrohyoid. Tips for the step muscle. During the thyroid surgery, meticulous dissection between the thyroid capsule and step muscle is key to get entry into avascular paratracheal gutter for bloodless operative field. And step muscle may be so thin in large gutter that may be confused as deep fascia, and we should remember it and try to preserve the step muscle as far as possible. In large gutter, if muscle need to cut for proper exposure, should cut above the level of innervation by ansa cervicalis at the junction of upper 1/3 and lower 2/3. This is the platysma muscle. This is the flat-shaped muscle extending from the mandible to the clavicles and lies enclosed within the superficial fascia of the neck together with cutaneous nerve and lymphatics. And tips for this regarding the platysma: should raise the flap in a avascular subplatysmal plane, and platysma is absent is midline, and should remember it, should identify it laterally. It is absolutely midline. Now the triangles of the neck. I think that everybody is oriented about the triangles. Sternocleidomastoid and trapezius divide the neck, anterior and posterior triangle, and anterior triangle can further subdivided into this submental, submandibular, carotid, and muscular triangle. Now I want to tell about the vascular arrangement of the neck. Regarding the vascular arrangement, we can divide the neck into three compartments. That is the superficial, intermediate, and deep. This is superficial, intermediate, deep compartment. Superficial compartment lies below the platysma and superficial layer of deep cervical fascia. It contains the anterior jugular vein, external jugular vein, and communicating veins. Tips for this first compartment: during the thyroid surgery, to dissect in midline between the medial borders of step muscles, stay between two anterior jugular veins. And anterior jugular veins may be more than two or even single in number. That is called the median cervical vein, and should be preserving the anterior jugular vein to avoid the postoperative flap edema. vessels of the intermediate compartment, that is the common carotid, internal carotid, external carotid arteries, and branches of the thyrocervical trunk. You have the pictures. The external carotid is important carotid artery. It originates from the carotid triangle at the level of upper border of the thyroid cartilage. Initially, it's found in anterior and medial to the internal carotid artery, and it takes a gentle spinal course then and goes to the anterior and then lateral position related to the internal carotid. It lies lateral to the styloid process and the connecting muscles, and 12 nerve passes lateral hypoglossal nerve, that is, and prosobranchial nerve passes medial to external carotid arteries. These are the branches of the external carotid arteries, of which the superior thyroid artery is important for us. This is it's the first branch of the external carotid artery, has a critical relationship with the superior laryngeal nerve, lingual artery, facial artery, branches of the thyrocervical trunk, and also the inferior thyroid artery. It is the branch of thyrocervical trunk. It is important that in its course, before supplying the thyroid and the parathyroid gland in level 6, it has an intimate relationship with the recurrent laryngeal nerve. That is, the recurrent laryngeal nerve may pass the superficial to internal inferior thyroid artery, may pass deep to the internal artery, and may between the branches of the internal inferior thyroid artery. Internal carotid no branch, and internal jugular vein is important. This is it is the continuation of the jugular valve, and in its level 2, it crossed on its lateral surface in descending order by the accessory nerve, spinal accessory nerve, occipital artery, digastric muscle. This tributaries of internal jugular vein, and vessels of deep compartment are vessels of multiple systems. Now the important nerves of the neck. This is the spinal accessory nerve, external nerve, internal nerve, and so on. I just touched the spinal accessory nerve, which is very important for us against surgeon. Spinal accessory nerve descends from the jugular foramen near the medial wall of the internal jugular vein, medial wall, and deep and posterior to the plane of styloid process. The superior branch of which is important. The superior branch of occipital artery intimately related with the spinal accessory nerve. Okay. Then the identification. One of the important things is that at this level, spinal accessory nerve associate with the anterior medial surface of sternocleidomastoid muscle in its upper third with anatomical variation. This is the anatomical variation, not penetrating, sometimes partially penetrating or completely penetrating. And the nerve enters the level 5 by crossing the posterior border of the sternocleidomastoid about 1 centimeter of arch point. Now the identification point of spinal accessory nerve during surgery. In 4th region we can identify at first entry point of sternocleidomastoid muscle along the anterior border of the sternocleidomastoid muscle, where the nerve is accompanied by the branch of occipital artery. Exit point, about to 1 centimeter of arch point. The arch point in the point where the auricular nerve emerges along the posterior border of sternocleidomastoid muscle. Also in the rope of the posterior triangle and in the lower neck, anterior rays of the trapezius, about the 2 to 5 centimeters superior to the clavicle. Here I have tips that careful elevation of the posterior skin flap is crucial to prevent the spinal accessory nerve. And at its entry point to sternocleidomastoid muscle, it is accompanied by the occipital artery. Can cause the bleeding during the dissection at this level, and injudicious use of diathermy to stop bleeding may jeopardize the spinal accessory nerve. Then this is external branch of civil now. We have another session where Professor Ashifur Rahman will discuss this NAT and duration. So that's all. Thank you everybody for patient hearing.